a COVID-19 patient with cytokine storm, admitted with fever, hypertension, respiratory failure, placed on mechanical ventilation, then developing hemodynamic instability, cytokine storm, hypercoagulability. He was placed on hemoperfusion for 3 days, leading to hemodynamic stabilization, normalization of cytokine levels, and decrease of inflammatory parameters with improved pulmonary exchanges until he was extubated. Not only that, we found an improvement in mean arterial pressure, diminished requirement of noradrenaline, and reduction of concentration of interleukin-6, but also improvement in function of the monocytes in terms of phagocytic capacity and production of mediators. Finally, monocytes were demonstrated to improve their function by an improvement in antigen presentation, as demonstrated by the improvement in HLA-DR expression and the number of monocytes expressing DR. This treatment has also been used in conjunction with ECMO in many patients, and you see here the typical, let's say, circuit in parallel with the ECMO circuit. So in conclusion, our recommendation, which has been published in Nature recently about these patients, somehow recapitulates the possibility to use cytokine removal, to use echoes, to use specific membranes, or to remove fluid in excess, and leading to an improvement of the condition of the patient. The recommendation, however, is to treat these patients quite early to avoid development of severe condition rather than cure them. As mentioned by our chairman at the beginning, you can follow many of our considerations on our YouTube channel called Cappuccino with Claudio Ronco, and I really hope that you can also follow next year meeting. Our meeting was just held in November this year. Next year will be in October, and if things will not be changing, very likely this will also be held virtually from October 26 to 28. With this, I thank you very much for your attention, and I thank you for this very kind invitation.
Thank you very much, Professor Ronco, and that, as expected, was quite enlightening, and I'm glad you also mentioned about the most contemporary topic as of today, and that's the way we should be handling COVID. But going back to the subject and something which is of common interest to us nephrologists and the cardiologists, may I set the ball rolling? And since we know that you have another commitment and you have to leave a little early, so we are having the question-answer session soon after right after your talk. And as I said, to set the ball rolling, may I take you back to when you coined this term, and then you had this typical cardiorenal and renocardiac in mind. Do you think it'll help us if we stage it further in the way we stage chronic kidney disease, stage 1, 2, 3, 4, and 5? If we were to subclassify cardiorenal syndrome as stage 1, 2, 3, trying to throw some light on the severity of a given syndrome, because I'm sure you will agree, we can't equate each and every cardiorenal syndrome alike. I mean, there'll be cases where the severity is quite minimal, and you may not really want to use your strong weapons in that case. So that's the first part of the question. And the second is that if that is the case, do you really believe in that the way you tackle a given situation, cardiorenal syndrome type 1 or 2, vis-a-vis 3 and 4, your line of management is going to change? So my question is, will subclassification alter your line of management, and does the existent classification indeed alter your line of management?
Well, thank you for this complex question. It may require actually a meeting itself to be for discussion. But in general, I can tell you this: it took approximately 10 years to familiarize with the classification of cardiorenal syndromes by cardiologists and nephrologists that initially were reluctant to accept a classification. We are aware that this classification is not perfect. However, it was not existing before, and since we started this classification, now cardiologists and nephrologists, they use a common language, and when they say cardiorenal syndrome type 2, they know what they mean. Now, it would be certainly time probably to start considering within a specific type of cardiorenal syndrome the level of severity. But there is more on this. There is evidence that one type may evolve into the other type. For example, cardiorenal syndrome type 1, some patients may not resolve acute kidney injury. And because they do not resolve acute kidney injury, they may end up with chronic kidney disease leading to cardiorenal syndrome type 4, for example. So I think it's extremely important to try to understand if there are interaction and evolution between the different classes. Furthermore, once the group are familiarizing with the definition classification, I think they may probably have the possibility to somehow stratify patients for risk and severity. And this would be the next challenge probably, but it should be done in conjunction, cardiology and nephrology together.
Yeah. So, Professor Ronco, a lot of questions, as expected, related to angiotensin receptor and neprilysin inhibitor, the typical sacubitril valsartan combination, and its role in comparison to SGLT2 inhibitors. We've learned a lot about these two molecules over the last 1 decade or so, or even shorter than that. So there are a few questions. So one is, do you foresee the role of ARNI in the mid-ejection fraction range? Of course, we know that it's been so far advocated for usage in HFrEF. So would you advocate its use in the mid-range? That's one, and I'm sure the cardiologists are going to throw light subsequently. So your take on that first.
I think that this is an area that we need to study because of the renalism, the nihilism in treating patients with chronic kidney disease in the past. We have lost opportunity to learn a lot in the pharmacological approach to these patients. I think today we cannot accept anymore this type of nihilism, and therefore we need to design specific studies on specific classes of patients. Now, in order to receive the most, let's say, suitable information, we need to be very strict in the enrollment of the patients and make sure that we are treating the same type of patient, the same type of characteristics. Otherwise, if the population is too heterogeneous, we may have positive, no result, or even detrimental effects. So we need to, we cannot accept anymore to speak about therapy in patients with reduced renal function. We need to speak about therapy in patients with CKD stage 1 and 2, CKD stage 3, 4, and 5. I think that this is the challenge of our next studies.
Professor Ronco, there has always been an apprehension, and we as nephrologists are always asked as to what is the cutoff GFR value beyond which you would not want to use RAS blockers, and ARNI would be an extension of the same question. So would you really advocate a particular cutoff beyond which you would not want to use valsartan as in ARNI?
Well, not really. People speak about 60, 45, or 30 milliliters per minute in GFR and so on. But first of all, I think we need to apply the concept of precision medicine. We need to consider that if the patient is accurately monitored, probably can be treated with specific drugs, even in presence of high risk for side effects. But if the nephrologist and the cardiologist have a specific combined clinic, these patients cannot probably be treated with these drugs, even in condition of mild to severe reduction of kidney function. Nevertheless, we need to monitor these patients, to have a frequent monitoring. If you consider, for example, the use of insulin in diabetic patients, you cannot recommend the optimal dose of insulin because you regulate this based on glycemia. I think that we need to monitor these patients with a continuous EKG, with a continuous possibly or at least frequent potassium measurement, and therefore we will find that at least a fraction of patients may benefit from these drugs, even in presence of severe reduction of kidney function. Again, we need to develop a better way to monitor these patients.
So the extension of that question would be, and as Dr. Ahuja wants to know, is there any evidence for ARNI in patients on hemodialysis? Would you be bold enough to continue use or initiate treatment with the sacubitril valsartan combination even when your patient has already reached a stage of dialysis?
Well, if they actually are, these are a group of patients that are optimally monitored because we see them every 2 days. Now, I would not recommend this in an area where patients are seen by the doctor once a month or once every 2 months. But if you, as in Italy, for example, these patients can be accurately monitored, and every drug can actually be used with attention, with prudent approach, but may display some benefit in some patients.
So in talking about the other form of therapy, and of course the obvious comparison between ARNI and SGLT2 inhibitors, so which do you think is the safer option now that we know that SGLT2 inhibitors have been found to be efficacious and safe even at GFRs of up to 25 ml with dapagliflozin? So which one would you believe is the safer bet for your patients with heart failure, ARNI or SGLT2?
Well, again, I think we have to consider a single case patient, not generalize this, because we have not done studies enough on this sense. But we should consider different outcomes. The outcome of worsening heart failure, and therefore ejection fraction. The second is presence of comorbidities. The third is evolving of kidney failure. So some drugs may present a benefit in one sense, but not in the other, and vice versa. I think we have to define first what is the endpoint while we're using this drug, and what is the final target you're trying to achieve. The most fascinating for us, of course, today is the combination of an acceptable ejection fraction in patients trying to reduce the evolution of worsening of kidney function.
So at this stage, I want to bring in Dr. Venugopal and Dr. Hari Krishnan. Dr. Venugopal, what you would want to know from Dr. Ronco, the way he would want to treat heart failure.
First of all, let me express our thanks to Dr. Ronco for an excellent review on the Cardiorenal Syndrome. There are a lot of questions that have come. As far as the mid-range ejection fraction is concerned, I think we will be prescribing ARNI in those patients, provided there is no renal problems, because there is no obvious data as to why it should not be used. So basically, I think all of us would agree that we will be using ARNI in these patients with mid-range ejection fraction. That's my viewpoint.
Yeah,
second thing is, the second question was about SGLT2, and I think it's again debatable, especially if the renal function is so bad, probably the SGLT2 inhibitors may not be useful in such a situation. This is my take on that. What would be
I mean, we are going lower and lower, Dr. Venugopal. I mean, we thought 60 would be the cutoff line, then came 45, then 30 with canagliflozin, now 25 with dapagliflozin, and finally with AMPA, we are going to have AMPA kidney come in, the results come in about year's time, and we will address the issue of 20 ml. Yeah. So I think, as Professor Ronco said,
it is coming basically, we have been keeping a level around 30 as the cutoff point for our practical use, especially in the general population physicians. So, you will be coming down and down. It's good for us. We have a good drug for treatment of heart failure. Because I have been once scolded by a nephrologist himself that you should not use it when the GFR is less than 30. So this is the point.
That's exactly why I wanted that question, Dr. Ronco, to address, because this is the commonest question we as nephrologists are asked, and I'm glad Dr. Ronco clarified that. And I think if you know that you will be able to monitor your patient well, then I don't think you have any reason to deprive him or her of the benefits of a potentially very useful class of agents, be it ARNI or SGLT2 inhibitors. Dr. Krishnan, your questions to Dr.
Regarding the mid-range ejection fraction, our National Heart Failure Registry of 10,000 patients also showed that mid-range ejection fraction patients benefit almost the same like reduced ejection fraction patients in Indian situation also. So that holds.
In fact, even if you look at the heart failure with preserved ejection fraction group, people who had a better outcome was those with a lesser ejection fraction in the HPF-EF group.
Yeah,
I would like to stress the importance of the control of volume in these patients, and I think that this should be a very multidisciplinary approach and combined, let's say, patient counseling and patient treatment and so on. Furthermore, I think that there is an area that we should consider that has not been well studied in the past, and it is the use of extracorporeal ultrafiltration, not for rescue therapy, not in conditions of, let's say, untractable fluid overload and pulmonary edema, but in condition of elective therapy from time to time in order to establish a very nice fluid and electrolyte equilibrium. And I can tell you that we are developing a system which we will call artificial diuresis, that is so easy to use, so simple to apply, even as a self-administered therapy for the patient, that probably we can have a very important result and new horizons in the field. And if you like, in the future, when we have the system completely developed, I will be delighted to have a study conducted in India, because I have seen a very nice collaboration between nephrologists and cardiologists like no other place, actually. So I hope that you can really be on my side in this concept approach for optimizing fluid management in cardiorenal patients.
I'm glad, Professor Ronco, that you brought it up, and I think that's the single most important determinant of patient doing well of cardiorenal syndrome. So I think I will take it further and need your strategies how to ascertain that most appropriate dry weight in your patient, which all tools, the easy ones, the subjective, objective, and finally the more sophisticated tools. And I would also like to draw your comments on the role of bioimpedance. I mean, something which we do very routinely nowadays for our patients on dialysis or even transplant patients to ascertain their dry weight. And obviously, we all know in the setting of cardiorenal syndrome, you can't afford to please hard at the expense of kidney or vice versa. So your take on the best methods of ascertaining dry weight?
Well, the truth is that we have to teach our students and young doctors about the message that Guyton gave us many, 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 many years ago. And it is heart, circulation, and kidney physiology. I think that if they know well the cardiorenal interactions and the importance of volume expansion, I think that they will immediately understand that there are determinants that may play an important role in worsening or improving function of each organ. As you can say, you cannot improve one organ at the expense of the other. So I think that the therapeutic window for fluid balance is very, very strict, very narrow in these patients. Sometimes 300-400 cc more brings the patient into pulmonary edema. 300-400 less brings the patient in intractable hypotension. So this is extremely important. I think that we should develop a better knowledge of bioimpedance, because this is an instrument that is simple and it can be measured and repeated the measurement several hundred times, like we can do for an online EKG or other things. The other thing is all instruments to remove fluid in the patient should be used with competence and very, very much attention. Most of the studies done on extracorporeal ultrafiltration in cardiac patients were done with people that knew very little about the concept of blood volume, relative blood volume changes, intravascular refilling during extracorporeal therapies. I think that these studies should be done by people that know exactly how to do, and once we have the results, which apparently are good in the hands of people that know how to do it, we need to teach people on how to do it. The same is very true for diuretics. If you give diuretics in a very, let's say, uncontrolled way, you may have detrimental effects. And rising serum creatinine is typical in the second or third day of an admission of a patient for heart failure. So diuretics are a potent drugs, but they should be used with attention, as should be for extracorporeal therapies.
Yeah, one question to Professor Ronco. So when will you consider not treating the patient with angiotensin receptor blockers or ACE inhibitors or ARNI? And when will you consider starting them on hydrolysine nitrate combination? Any recommendations?
Well, again, it's a kind of evaluation you do at the side. My suggestion is, and I think we were successful in this, go at the bedside together, the cardiologist and the nephrologist, and discuss case by case the advantages and the disadvantages. Of course, as a nephrologist, you can somehow make safe the use of ARBs and ARNIs in patients in which initially it seems that side effects may advise not to go for it. Or at the same time, if these side effects continue, you may actually say this is the case to discontinue and go for different solutions. The same is true for diuretics. I think that diuretics are important depending also on the target you want to achieve. Because if the target is acute decongestion and improvement in symptoms, this is one thing. But if you want to have long-term reduced rate rate of rehospitalization, you need to achieve a much better and stable control rather than doing an acute dehydration of the patient. So I think that every patient should be discussed at the bedside. I mean, I try to teach my fellows, look less at the computer and go more at the bedside of the patient and go there together. Maybe I'm Italian, so it's a kind of a different approach, but the defect of our American friends is that they work with numbers. They don't work with patients. And I think that, I've worked in America enough to say that. America is great, but the young American fellows just look at the computer. They don't look at the patient.
Dr. Chopra, you have any comments or questions for this thing? So before I hand it over back to Dr. Venugopal, there have been a few other questions, probably a little unrelated, but I think we'll take advantage of this opportunity to ask you, is it important to treat, as Dr. Bhattacharya wants to know, to treat asymptomatic hyperuricemia in chronic kidney disease?
I think so. Because uric acid is a dangerous molecule. It increases inflammatory response. It has a direct damage into the cells. And somehow it is a reflection of a hypercatabolic state. So in my opinion, it deserves to be treated, even if asymptomatic.
So thank you so much, Professor Ronco. I think this discussion can go on, and I think we are really very fortunate to have you over here today. And for the time constraints, I'll hand it back to Dr. Venugopal for the further proceedings. Thank you once again, Professor Ronco.
I will send you by email the titles of the books that can suggest to your young fellows.
Sure, great. That'll be great. Thank you so much.
Thank you so much. Thank you so much, Dr. Ronco, for an excellent presentation. And we enjoyed the whole time, all your wisdom, the years of wisdom that you have with you. Now, I think we'll go back to the next part of the program, that is a case presentation. This is a cardiologist's perspective on cardiorenal syndrome. And there'll be two case presentations. First case will be presented by Dr. J.C. Mohan, and then the second case by Dr. B.K. Shastri. May I now call upon Dr. J.C. Mohan to present his case. Then we have the discussions. We'll take one case and then the discussions, and then we go to the next case. Dr. Mohan.
Thank you. At the outset, I express my gratitude to Heart Failure Association of India for having invited me to present this case in an important webinar where Professor Claudio Ronco was the speaker. I'm going to present you our viewpoint on cardiorenal syndrome or renocardiac syndrome by way of presenting a 66-year female patient with worsening heart failure and renal insufficiency. Dr. Ronco mentioned that there is a long-term bidirectional relationship between heart and kidneys, and that is because they both have common risk factors and common shared pathophysiology. And he also mentioned that at the moment there is a syndemic of heart failure and kidney disease. Currently, anything between 20 to 65% of all patients with heart failure have significant CKD, that is stage 3 or more. And we also have learned over a period of time by studies, basically in hypertension, that kidney is the epicenter of synthetic overactivity and angiotensin II in heart failure. With that preamble, let me take you the case. This is a 66-year female with diabetes, hypertension. She had an old anterior marker infarction, bypass surgery in 2009, and she's now in heart failure with ejection fraction of 28%, some mitral regurgitation, scarred LAD territory, and she has class 3 symptoms of heart failure, and she's hemodynamically stable. Her therapy includes carvedilol 6.25 milligram once a day, twice a day, 3.125 milligram, ivabradine, digoxin, furosemide, sitagliptin, metformin, gliclazide, and rosuvastatin. That is as it was on June 3, 2018. Her investigation revealed that the diabetes was not controlled. HbA1c was 8.4, serum creatinine 1.6, raised blood urea 54, electrolytes all right, somewhat raised uric acid, which we just discussed, and of course the lipid profile, which was typical of atherogenic diabetic dyslipidemia and some anemia with hemoglobin of 10.7 and 1 plus urinary protein. She improved with increasing carvedilol to finally 25 milligram a day, which means 12.5 milligram twice a day, addition of 5 milligram ramipril and 25 milligram spironolactone. This is triple guideline-directed medical therapy, so right things have been done. However, despite the guideline-directed medical therapy, she was readmitted 3 months back, 3 months later on with the worsening heart failure, and her creatinine rose slightly, her blood urea went up a little bit, sodium went down a little, indicating some dilutional hyponatremia. And of course, at this time, examination was exactly similar to what she was having earlier when she had ambulatory heart failure. But patient did have evidence of old antiviral infarction and mild right-sided pleural effusion and a BNP of 680 picogram per ml. So these are the investigations which show actually old antiviral infarction, sinus rhythm, and the QRS duration is 106 millisecond, and it is necessary for us cardiologists to mention that, and of course cardiomegaly with pulmonary venous congestion. Echo showed, of course, an ejection fraction close to 30%, wall motion abnormality in the territory of LAD and large left atrium. And of course, the Doppler study did show a dilated inferior vena cava, evidence of pulmonary artery hypertension and restrictive transmitral flow pattern, indicating significantly elevated left ventricular filling pressures. So she was treated with the intravenous torsemide. She was decongested. 1 gram of ferric carboxymaltose was given because the RN levels were low and the ferritin level was low. She was vaccinated for flu and pneumonia at the time of discharge, and guideline-directed medical therapy, which was being given, was continued. So, but she continues to need some IV furosemide once in a while, and she visits the emergency department or at home she needs furosemide because she gets out of breath and she has restricted activity. We know that people with worsening heart failure, as the Trivandrum heart failure registry also showed, have mortality which is nearly 3 times more than people who are relatively stable and don't have worsening heart failure. Let us come back to our point that she has an eGFR of 39 ml and blood urea nitrogen is 36. Now, this is class 3B, the stage 3B of CKD. And some of the data which we published actually last year showed that stage 3 CKD in patients who have been discharged from the hospital after adequate decongestion is there in about 3 or more, is present in 29% of these patients. So nearly 1/3 of the patient have stage 3 or more CKD, like our patient. However, data from the Western world shows a greater prevalence because those patients are older, and this is data from Swedish heart failure registry showing that stage 3 CKD is present, stage 3 or more CKD is present nearly 45% of heart failure with reduced ejection fraction and more in HFpEF. The data from the ADHERE registry also says that only 9% of the people have normal eGFR. So our patient, of course, we need to classify, as Dr. Ronco said, what is it? You might say that, well, it looks like a type 2 cardiorenal syndrome. Patient has heart failure and has a eGFR of 39. You could also say it is a type 5 CRS because the common pathogenesis is diabetes. Diabetes is there for 14 years, so this could be causing both the things, and this could be a type 5 cardiorenal syndrome. In patients with heart failure, what causes actually reduced renal function, reduced cardiac output, reduced renal blood flow, and of course reduced blood pressure. The consequence of that is that there is an increased total body water, total body sodium, and of course increased extracellular volume and plasma volume. Renal dysfunction in heart failure, even if there was no diabetes, usually because of hypoperfusion, venous congestion, inflammation, and oxidative stress. And Dr. Ronco went into great details in discussing the venous congestion. Finally, that results in renal interstitial hypertension, reduced renal salt and water excretion, reduce renal blood flow, reduce EGFR, and of course, overactivation of sympathetic nervous system and RAS system. And he did mention that the hemodynamics, whether it is because of diuretics or hypoperfusion because of the worsening heart failure, leads to worsening renal function, which feeds the heart failure by renin and angiotensin activation, and as well as, of course, the sympathetic nervous system activity. Our patient is an EGFR 39. We have data actually that in diabetics, chances of hospitalized for heart failure are high in those people who are EGFR, low EGFR actually, compared to more than 60. Our patient has a 4 times high chance of developing hospitalization for heart failure. And of course, this thing has been already discussed by Dr. Ronco. I wouldn't go in detail, but what is important actually in our particular patient is the hazard actually of mortality in heart failure keeps increasing as the EGFR keeps going down. And with our patient having actually a 39 EGFR, it is marginally increased compared to a person who has nearly normal EGFR. So problem-oriented medical record of this patient is we need to actually aim at prevention of recurrence of heart failure, management of ambulatory heart failure, management of type 2 diabetes, management of CKD, management of anemia, for which we already gave ferric carboxymaltase, and what additional measure we can take for coronary artery disease and dyslipidemia. For the moment, we will not be discussing coronary artery disease and dyslipidemia. Principles of optimizing care in heart failure in this patient. Of course, you achieve the target dose. We are on 25 milligram carvedilol. We can increase that. Look for iron deficiency. We have done that. Optimize guideline-directed medical therapy, where comes the role of course, ARNI. Modulate heart failure. And of course, we did discuss ISD and hydroxyzine combination. But we can shift to ARNI. This patient is on ramipril, and that's a reasonably good approach in a patient who is not so well controlled on ACE inhibitors. Of course, we need to manage the comorbidities, including CKD, better. So I was able to take carvedilol dose to 50 milligram twice daily. Actually, that's a pretty stiff dose, and final heart rate was 66 beats per minute. Some help was also taken with the help of ivabradine in this case. The issue of beta blockers are actually much more useful in patients who have CKD than those people who in fact don't have CKD or have mild CKD. Data from the MERIT-HF trial shows that number needed to treat with beta blocker in preventing mortality just 4 in case the EGFR less than 45. So the most important thing in this particular patient with an EGFR 39 is beta blockers, and that is exactly what we have done. What about MRA? We have continued spironolactone, and the issue is the EGFR 39. You are worried about hyperkalemia, and we are also, so you need close monitoring, as Dr. Ronco said. But people with low EGFR or EGFR above 60 draw similar kind of benefit from MRA like spironolactone, as shown in this trial, although the chances of developing hyperkalemia are twice more, and the reticence of not using spironolactone stems from misfear of hyperkalemia. At least 75% of the patients are not going to develop hyperkalemia, and 90% time you can continue spironolactone in such type of EGFR without stopping the drug. So the patient is on triple therapy, still symptomatic, HbA1c is 8%, and of course hemodynamics are stable. So let us try to fill the therapeutic hole in this heart failure with DKD. I replaced ramipril with ARNI, as I said, after 36 hours gap, 100 milligram twice a day, and the guidelines also recommend the same, that you should shift to ARNI in symptomatic patients with HFrEF. And of course, the ARNI has big advantage because it is a dual modulator. We wouldn't go in detail, but the great advantage in patient EGFR is when you compare actually the paradigm HF data, and there is enalapril compared to ARNI, reduction in EGFR, annual reduction in EGFR actually is much more slowed in case you use ARNI compared to enalapril. Same kind of data actually is available in Paramount study, which essentially is a study of HFpEF, which shows that ARNI compared to valsartan slows the reduction in EGFR much more significantly. This is nearly 3 times greater benefit with regard to slowing the kidney disease with ARNI compared to valsartan. So and same thing is true for Paragon also. In Paragon HF study also, whether you were using MRA or without MRA, there was actually a similar kind of benefit. So the predictors of successful initiation of sequel or ARN in this patient are already there. The blood pressure above 120, there is a prior hypertension, and there is no atrial fibrillation. So out of 6, 3 things suggest that the patient would tolerate sequel, and if possible, take it to 200 milligram twice a day. The next issue, of course, is that the HbA1c is still 8%. So I decided to use dapagliflozin because, and that was started a year after, actually, somewhere in September 2019, when we had data coming from the DAPA-HF study, because the data strongly suggests that the drug reduces hospitalization for heart failure and, of course, cardiovascular mortality, regardless of the EGFR. People with EGFR less than 60 or more than 60 had equal kind of benefit. And over a period of time, starting beyond 12 months, the decline in kidney dysfunction is slowed by dapagliflozin. It's not an immediate effect. In fact, immediate, there can be worsening. And of course, these patients require close monitoring because a substrate of vulnerable patient, ARNI and dapagliflozin, may develop acute kidney injury. So drug regimen in this complicated patient was, I stopped digoxin because I wasn't, the safety therapeutic range was narrow, looked for iron deficiency, corrected it, kept the heart rate below 70, shifted to ARNI, did not worry much about dyslipidemia because I thought that is not a step. And to prevent progression of CKD, I did not use uric acid lowering drugs or phosphate lowering drugs or vitamin D3. And I disagree with Dr. Claudio that there is any big data to suggest that uric acid reduction really helps in these people. I used dapagliflozin for better control of diabetes and heart failure. Patient was vaccinated for flu and pneumonia and did look for reversible ischemia. I thought that wasn't a great thing. There are, of course, unresolved issues in this patient. You might think phosphate reduction might work, uric acid reduction may work. I'm not too sure. Digoxin use, which way, whether I can use it. As I said, I'm a little reticent about using digoxin. EPO, I think the red HF trial was negative. I don't use EPO despite the hemoglobin being low. Finrenon may have a great role to play, especially if the patient develops hyperkalemia. And now with Fidelio DKD study, things look very positive. Role of ICD can still be there, but the data also suggests that people who actually have EGFR, which is less than 60, draw much less benefit from ICD. And this is really patient level, largest meta-analysis available till date, which says probably people with EGFR, which is low, do not benefit from ICD. So I did not consider ICD in this patient. Last seen, December, last month, patient is class 2, HbA1c now 7.3, heart rate is 64, serum creatinine 1.2, EGFR 46, somewhat better. Echo is performed, and now, of course, there is a reduction in pulmonary pressure, and now it is actually more delayed relaxation of grade 1 diastolic dysfunction. So, ladies and gentlemen, to summarize, I presented to you a case of worsening heart failure with CKD, stage 3B, and I told you my approach. And I would like to say that I would rather like to say beginning 2021, whenever you see a patient with HFrEF and CKD, ask yourself a question: why is this patient not on ARNI and SGLT2 inhibitors? I'm not sure about lowering uric acid, giving soda bicarb, phosphate reduction, and acetylcysteine. I don't think these work. At least I don't have data, and I would probably try to stay away from that. Thank you very much.
Thank you, Dr. Mohan, for an excellent case. I think there is nothing more to add to the management. You have done an extremely clear way of managing this patient. Whatever the guidelines say, whatever we know about heart failure management, except for the ICD and the rest of it, you have brought in everything in clear perspective. Hari, any comments?
No, only thing is that one point which I to consider whether the revascularization in this patient and to look for ischemia. That was only point of difference from Dr. Mohan. Otherwise, everything he has suggested. So always ischemia should be a point of whether we can have some improvement, unless the echo, whether he has in data to show that the echo wise the myocardium is scarred and there is nothing to improve.
I thought the echo was more of in favor of a scar in the LAD territory.
Yeah, probably he had that in mind.
Maybe the reason why Dr. Mohan also did not think his correction of ischemia may be a very, very important thing. Yes, Dr. Kuller.
Yeah, so thank you very much, Dr. J.C. Mohan, and as always, it's always a treat to listen to him, and I think such a lucid presentation every time, and you tend to learn. Dr. Mohan, I would totally agree with the way you manage your patient, and basically this is in response to your last queries in relation to uric acid and bicarbonate. Well, of course, uric acid is debatable, and there was a time about 5 to 10 years ago, we were all very much optimistic about treating even asymptomatic hyperuricemia in chronic kidney disease, because there was some initial data which subsequently, as you rightly pointed out, could not be substantiated. So we're not very sure about managing uric acid hyperuricemia, and especially there was controversy when it came to lowering it with the help of ibuxostat, and there's another controversy with the usage of ibuxostat now. But about bicarbonate is the real controversy. On one hand, we as nephrologists would certainly be wanting to keep our patients' bicarbonate value as close to 24, definitely over 22 milliequivalents. But the real problem is, and there are enough studies which have shown there is a reduction in the rate of deterioration of chronic kidney disease when you're treating them with alkali. But the problem here is giving them sodium bicarbonate in a patient who's already volume overloaded. On one hand, you are wanting to discourage the use of sodium and you're restricting sodium. Obviously, giving them bicarbonate, at least when they have a significant cardiorenal element, would not be judicious. So maybe once, as you have already pointed out in your patient, the GFR has improved. It's already much better at 1.2 than of creatinine than what it was at 1.7. If it improves further and heart failure is settled, with the help of ARNI, you have improved the patient's ejection fraction. Probably subsequently we can think of adding a cautious use of sodium bicarbonate as well. But yes, and equally important is I think, which cannot be overemphasized, is to determine, and the question which I had asked Dr. Ronco as well, you have to determine the right dry weight for your patient. Otherwise, you are going to err. And I think that's the beauty of learning with your own experiences. It's just not the time-tested, looking at the skin turgor and pitting edema or not. I think we have to advance much more than that. And with that in mind, we are now taking the help of bioimpedance. It's a small machine. It's handy. You get the report within 5 minutes. And of course, the cardiologists always tell us the importance of the IVC filling. I think we need to have objective ways of knowing our targets. Otherwise, the same thing, we will be pleasing the heart at the cost of the kidney and vice versa. Thank you once again.
Currently, we use actually lung ultrasound to monitor volemia. It is extremely cheap, very easy to do. Any machine can do it. And you get, if you see B lines which are more than 1, 2, if they're 0, it is absolutely fine. But if they're 1, 2, you are very happy. But you will see 5, 6, 7 lines, certainly more needs to be done as far as this correction of hypervolemia is concerned. And I strongly urge through this platform that people should use lung ultrasound much more. It can be used anywhere, whether you are in ICU, you are in ward, patients come to OPD, just have a quick look. It will take probably 3-4 minutes actually. Like you said, bioimpedance is a much easier way of sorting out the issue.
Quite cheap and effective, and I think it's revolutionized the way we manage our dialysis patients, because it's all about taking appropriate care of their fluid management. So I think tools like these, you can't blindly follow them, of course. You ultimately will have to rely on your own clinical judgment, but they certainly are good objective tools to help you.
Yeah, actually one of the chap who is now actually the Chief of Medicine and Cardiology in Morgantown, West Virginia University, and he was my fellow. He just published some work showing that the B lines actually are a much better way of following and prognosticating these individual heart failure. Not only these correlate with the filling pressure, the total body volume, but they also correlate with prognosis.
Quite true, totally agree.
Can we go to the next
case? Yes.
The time is...
Dr. Shastri?
Good evening, everyone. I thank Catheterization of India for giving me this opportunity. Unlike the previous case and unlike the previous speakers, my presentation is going to be a little different. I am basically presenting a case just like a third-year resident, and I want the opinion from the experts, how it is to be managed, what mistakes I did. Now, this is going to be essentially a case presentation and very little theoretical discussion. This is going to be a lengthy, complicated case, likely to be controversial. Please bear with it. My patient is a 56-year-old male patient. He presented to us on 22nd March 2016. He was a known hypertensive on valsartan. He has a family history of coronary disease, but no diabetes, non-smoker, no habits. And he presented to us with class 2 dyspnea, abdominal discomfort, and edema feet. He had elevated jugular venous pressure. Pulse rate was 140/80, and he has pansystolic murmur suggestive of tricuspid regurgitation. His ECG showed biatrial enlargement and left ventricular hypertrophy. Chest X-ray showed cardiac enlargement, right atrial enlargement, SVC was dilated, pulmonary venous hypertension was there. Echocardiogram, biatrial enlargement, moderate MR, severe TR, good LV RV function. For want of time, I am not showing. I request you to take it at the face value. These findings are real. His routine labs were normal except for a diagnosis of hypothyroidism. His newly detected hypothyroidism. His ultrasound abdomen showed mild hepatosplenomegaly, ascites, and bilateral pleural effusion, all suggesting to congestive heart failure. He has PET CT to rule out any inflammatory cardiomyopathy, which was ruled out. Sarcoidosis was not there, or any inflammatory pathology was not there. His cardiac MRI was done, which was suggestive of restrictive cardiomyopathy, but there is nothing like amyloidosis or other infiltrate or storage disorders. He had hypertrophied interventricular septum, biatrial dilatation, patchy left ventricular, right atrial, left atrial free wall and IAS scarring, severe mitral regurgitation, moderate tricuspid regurgitation, normal sized left ventricle and right ventricle with good function. So a diagnosis of idiopathic restrictive cardiomyopathy was made. He is treated with diuretics, Lasix 40 mg, valsartan and metoprolol were continued. He was relatively stable for nearly 2.5 years, or from 3.5 years rather, from March 2016 to October 2019. He was in function class 2. At the end, towards the end of this time period, he is slowly increasing breathlessness. Serial echocardiograms done over a period showed gradual increase in left atrial and right atrial size, which I'll show you a table. While LV size and function remained normal, at the end of the period, by October, his RV was started dilating and there is mild RV dysfunction was there. His biochemical parameters throughout the period were stable, except blood urea and serum creatinine started increasing by October 2019. So this is the chart you can see. The urea creatinine, but more or less okay. By 16th October 2019, his urea creatinine started increasing. His bilirubin and sodium potassium hemoglobin were faded. So first time he is admitted in 16th October 2019 with increasing shortness of breath, orthopnea and abdominal fullness. As I mentioned, urea creatinine were elevated. Patient, we thought we'll do a right heart catheterization and angiogram and see if anything more information we can get. When we did right heart catheterization, he has severe pulmonary arterial hypertension. Angiogram showed non-obstructive coronary artery disease. Heart transplant was considered inappropriate. I'll show you the data. So we just increased the dose of diuretics and continued valsartan and metoprolol. So this is the first cardiac catheterization done on 16th October 2019. His capillary blood pressure is 29. PA was severe PAH with 53 mean. Right ventricle pressures, right atrial pressures are all elevated. Please note the cardiac output is quite low, 1.75 liters. Cardiac index was 0.92. His trans pulmonary gradient was 24, PVR was 13.7. So this data is quite inappropriate for us to submit him for the surgery, transplant surgery. So he continued to be symptomatic, and we discussed with transplant surgeons, one of the eminent surgeons in the country. The family was not very keen, but borderline, they were willing to go if it's required. So the
cardiac surgeon, the experienced surgeon, suggested to look at hemodynamics on Milner infusion. At the first sight, it looked very odd for me because his LV function was good. RV function was not bad. Looking back, it was probably mild RV dysfunction. So anyhow, because of his wisdom, we thought we'll try. So he was admitted on 8th January 2020. He received Milner infusion from 8th January to 13th January, and we did a repeat right heart catheterization. Even then, the right heart pressures are pretty high. So he was contraindicated for orthotopic heart transplantation. And because of restrictive cardiomyopathy, good LV function, neither a candidate for LVAD. Options are heart lung transplantation or heterotopic heart transplantation. For either of us, the patient refused. The question is, how can we reduce the pulmonary artery hypertension with medication? Can we ever make him a candidate for heart transplant? Now, these are the parameters before the Milner infusion. I want you to pay attention. This is basically we are discussing about Cardiorenal Syndrome. If you look at it on 7th January, he had 70 urea creatinine 2.07, some 2.4 on creatinine 9th January. We started Milner infusion. Over 6 days, the urea creatinine have remarkably decreased and almost became normal. Please note that the bilirubin also was elevated, part of heart failure, which decreased. This NT-proBNP is picomoles. This will translate to approximately about 2,000 picograms. Now, second cardiac catheterization showed still the pulmonary capillary wedge pressure and right atrial mean pressures are elevated. However, there is significant fall with Milner and Lasix infusion in the capillary wedge pressure from 29 to 20. RA mean pressure decreased from 30 to 18. Cardiac output and cardiac index have increased, but pulmonary vascular resistance remained high. So there is a fixed component of the pulmonary arterial hypertension. There is a long-standing restrictive cardiomyopathy, increased backward pressure, remodeling of the pulmonary artery, and fixed component of the pulmonary hypertension. Obviously, with a PVR of 16.8, nobody will submit him for any heart transplantation. So we decided to manage him conservatively, whatever treatment we can give. In the next month, he again came with worsening heart failure with class 4 symptoms and orthopnea. His creatinine was initially 2.17. Again, we gave intravenous Milner and Lasix. He became symptomatically better, and again, creatinine improved. So we were wondering how to deal with this. After going through the literature, which I'll discuss later, very cautiously I started him on pulmonary vasodilators, both sildenafil and macitentan. I keep talking about this all the time, that in the group 2 pulmonary hypertension, generally we don't give pulmonary vasodilator, but I have taken a decision to give sildenafil and macitentan to this patient. Now, the renal parameters on Milner infusion in February, you can see on 3rd February, urea creatinine are elevated, but as I started Milner infusion and pulmonary vasodilators and Lasix infusion, the urea creatinine gradually increased by 10th, but when we stopped it, for a period of time, they again gradually started increasing. So anyhow, we can't continuously be giving Milner infusion. We sent him home on increased dose of Diuretics, sildenafil and macitentan after observing for a few days in the hospital. Then from March to September, it is a lockdown period. He is an employee and probably he applied sick leave or there is not much of activity. He was seeking telemedicine consultations. And gradually, though he said he was all right, probably is not exerting much. His creatinine and urea, which he got from the local labs, started gradually increasing. Because of the increasing edema and breathlessness, we started metlazone, also increased diuretics. So, and again, we played with it to increase and decrease like that. However, by 8th December, he came with significant worsening of symptoms. He had admitted for worsening heart failure, increasing dyspnea, edema of feet, abdominal fullness. His activities of the daily living were impaired. His creatinine at the time was 2.5 milligrams. Because of this grossly fluid overload condition, I sent him to a nephrologist for regular dialysis or ultrafiltration. Patient refused and wanted to try Milner infusion once again, as he felt better earlier on 2 occasions. So we thought, okay, we will try the same. Unfortunately, iatrogenic, he developed primary bloodstream infection with gram-negative bacteria in the hospital. For a few hours, urine output dropped and creatinine increased for a couple of days. However, his sepsis responded to IV antibiotics. He became febrile and urine output improved. So on 11th or 12th, we got him admitted, one of the days. His creatinine was 2.54. After admission, I told you because of the gram-negative septicemia documented, his creatinine jumped, urine output dropped, but once with antibiotics it decreased. With continuing Mildenol infusion and Lasix infusion, his creatinine improved and urea creatinine came down to 90 to 1.2. He was diuretics as well. He lost about 4 kgs of weight. On 21st, with continuous Mildenol infusion, on 21st December, with the continuous Mildenol infusion, creatinine decreased from 2.5 to 1.8. It was stopped, but Lasix and Metrolizole were continued. He further lost weight. He complained of weakness. Systolic blood pressure was 90. However, high diuretics but no Mildenol, urea increased to 149 from 92, and creatinine also increased. So both cardiac output and this highlights the importance of the forward failure as well as the backward failure. Cardiac output should be optimal and congestion should be minimal. So in this, if you don't tweak them properly, urea and creatinine keep increasing. So he continued on the diuretics. We didn't continue Mildenol, as I mentioned, forever. We initially gave for 4 days. Again, during Mildenol infusion, creatinine dropped. Once we stop it, it is increasing. So as on today, his systolic blood pressure is 100 millimeters. Urea was 114 and creatinine is 1.9 milligrams. So these are the serial echocardiographic findings. I'm sorry I'm not showing the pictures because of for want of time. As you see, the right atrial size gradually increased over a period of 3.5 years. And left atrial size also gradually increased, showing the progressive nature of the restrictive cardiomyopathy. LV function remained the same. Ejection fraction was good all through. Right ventricle started worsening in 21st, in the early mid of 2019, and it gradually worsened. Probably this indicates the fixed increase in the pulmonary hypertension fixed component. And as the RV dysfunction worsened, his creatinine worsened, his symptoms worsened, and his pulmonary systolic pressure was always high. He always had severe mitral and tricuspid regurgitation and IV sequence fluid overloaded. So points for discussion are: this case typically illustrates changing renal function with Mildenol infusion and diuretics as a function of changes in the cardiac output and filling pressures. Whenever the cardiac output increased with Mildenol, the urea creatinine decreased. Along with diuretics, when you are giving the decrease in the filling pressures, urea creatinine decreased. So what is the etiology of this heart failure? It's obviously restrictive cardiomyopathy, most likely idiopathic. This patient has to start with some concentric hypertrophy. There is a genetic variant of hypertrophic cardiomyopathy progressing to restrictive cardiomyopathy. There is no way of knowing it. I am not sure. For all practical purposes, it is idiopathic restrictive cardiomyopathy without any specific treatment. Now, efficacy of Mildenol and use of pulmonary vasodilators in this case we will discuss further. I should have considered heart transplant in this patient much earlier. This is one of the lessons I learned in this patient. And this patient belongs to type 2 Cardiorenal Syndrome. There is no need to emphasize, we have heard so much about it today. And all these factors, this fact has been emphasized: low cardiac output, all these things, chronic hypoperfusion, increased venous pressure, increased venous resistance, genetic predisposition, anemia, all these things contribute in chronic heart failure to initiation of the kidney damage and progression. Now, rationale of medication in this patient: when we are giving the high diuretics, because they decrease the central venous pressure and the renal venous pressure is decreased, this patient felt better. Why not ultrafiltration? We will discuss this in the next slide. Patient got Mildenol and he felt better. It is intuitive that in the presence of good RV-LV function, Mildenol should not be helpful. But as I mentioned, his worsening started when the RV started dilating and dysfunction. RV dilatation is generally a sign of failure in the presence of pressure and volume overload. And this patient has both pressure overload with a high PVR as well as the severe tricuspid regurgitation. And there is likely to be RV outflow mismatch. No, we could not pick up there is a myocardial dysfunction which responded to Mildenol. The ventricular arterial decoupling must have been corrected, and pulmonary vasodilators in the sometimes the pulmonary hypertension in the presence of severe pulmonary venous hypertension can go through three phases: mere passive backward transmission, vasoconstriction, or fixed changes. Probably because of the long-standing severe pulmonary venous hypertension, this patient has severe remodeling and severe fixed pulmonary hypertension, which may not regress with pulmonary vasodilators, but there are some case reports. I'll show you. Coming to the ultrafiltration, why this patient was not a candidate for ultrafiltration? This is a controversial area. Even 2017 ACC/AHA guidelines recommend ultrafiltration in some patients. Occasional patient may really get benefit, but 4 clinical trials, which of course involved mostly the cardiorenal type 1, they did not show much benefit. There is increase in plasma renal activity with ultrafiltration than stepwise pharmacological care. Increased plasma renal activity is not good. There is larger rate of fluid loss, but no change in the serum creatinine as shown in the unload and rapid heart failure trials. There is no significant difference in weight loss at the end of the study in all the studies. There is increased serum creatinine of 0.23 milligrams versus a decrease of 0.04 with diuretics in the CARES heart failure trial. Higher rate of adverse events with ultrafiltration in both CARES heart failure and AVOID heart failure trials. And there is no significant correlation for reduced heart failure admission at 90 days in AVOID heart failure trial. So taken everything together, ultrafiltration is not particularly beneficial over the gradual incremental discrete use of the diuretics. However, the occasional patient may get benefited. Now coming to the pulmonary vasodilators, these are some of the case reports I thought interested people may read. There is a case report published in Pulmonary Circulation that long-standing idiopathic restrictive cardiomyopathy, there is a reversal of pre and post capillary pulmonary hypertension. Patient became a transplant candidate. Similarly, similar reports are reported case series are reported from other authors. With this, I close my session talk. Thank you very much.
Thank you, Dr. Shastri, for that excellent case presentation. I have one question to ask you. See, all throughout the MR is severe. Do you think that tackling the MR in any way would have changed anything in this patient? Because all throughout the MR is severe. So is there any, looking at that MR, is there any?
Mitral clip or something.
Yeah, something, that is my,
also,
every time it is severe MR. So doing something like a mitral clip, would it have made any difference?
I'm not sure. If you have got a very good systolic function and severe pulmonary hypertension, long-standing, I wonder if the severe MR surgically, I don't know, if it would have come out of surgery with such a severe pulmonary hypertension and the onset of right ventricular dysfunction. Mitral clip is still, I don't know, practically it is not practical. At least in our center, we have not seen it not being done. But maybe, I don't know, possible.
So the starting point of development of pulmonary hypertension is the elevated both due to MR and both due to the restrictive cardiomyopathy. So that has probably tilted the balance of this patient going to RV dysfunction and renal failure. Probably that was the point of discussion, whether the MR tackling non surgically, whether that is an option.
So LV-EDP is 30. In the presence of severe mitral regurgitation without a dilated left ventricle, without being acute MR, LV-EDP 30 means intrinsic myocardial disease of the left ventricle. In such situation, if you tackle the MR also, they will continue. Of course, MR would have added to the pulmonary venous pressure, but LV-EDP itself is high. With a normal size left ventricle with a high LV-EDP means it is an intrinsic myocardial pathology.
The comments?
Dr. Shastri, I think if there is severe MR, LV has to dilate. There is no way LV would not dilate. And that is why the echo data which you have shown, the LV is dilated all throughout. Even 55 millimeter is dilated LV in this country, where average actually the LV size about 47 millimeter. And either the severe MR has to be wrong or the LV dimensions have to be wrong in case LV is not dilated. But your point that whether mitral clip will help these people or not, we have no idea. Certainly nobody has used this stuff in restrictive cardiomyopathy with severe MR. That is true. But your use of pulmonary vasodilators is interesting. And now that I recall, we have used as a desperate measure in some patients with reasonable results. Never had the courage to show these cases to anybody. Why your case, at least we are now feeling that in some patients, as a desperate measure, endothelin receptor antagonist probably could be a choice of treatment.
Yes, sir, your point is well taken, sir. I mean to say when the LV is not dilated, it's not like a common garden rheumatic mitral regurgitation or MVP MR. There is obviously some dilatation of the left ventricle, but not the usual common mitral regurgitation.
In our earlier, we used to think of left ventricular renomyocardial fibrosis, not a dilated LV. Then you have severe MR and severe pulmonary hypertension. In fact, we even used to diagnose precapillary pulmonary hypertension patients with LVMF. Now we are not seeing those cases at present, but when you suspected a restrictive cardiomyopathy, this is one of the thoughts that went through my mind, especially because of very severe pulmonary hypertension. But your cardiac MR did not show any evidence of EMF.
EMF, no, sir. No. It has repeated 2 times. Yeah. And echocardiogram with different operators have seen experienced operators.
There is definitely data in heart failure with preserved ejection fraction. You have 2 types of patients where people have severely elevated pulmonary hypertension documented as a result of both precapillary as well as postcapillary hypertension. And those with the precapillary tends to do very badly when compared to those with only mildly elevated postcapillary pulmonary hypertension. The exact etiology why they go in for a primary vascular disease, pulmonary vascular disease, is not clear. But then that is probably what prompted you to use the pulmonary vasodilators.
Regarding the use of pulmonary vasodilators, the Pro Kerala registry of 2,000 patients of pulmonary hypertension, 60% of the patients were having a type 2 class 2, that is left heart disease. 5% of the patients were prescribed pulmonary vasodilators because people consider that there is no other option, like Dr. J.C. Mohan has said. So people are prescribing as a last resort in such patients when there is no other option.
We can use pulmonary vasodilators, but you should know that the target is left atrial hypertension than pulmonary hypertension alone. So without giving adequate diuretics, you give only pulmonary vasodilators, there can be problem. You have to give very high dose of diuretics and make sure that positive cardiac output is maintained with good inotropy.
Is there any chance of an autoimmune disease in this patient?
Unlikely, sir, because 4 years we have seen and there is no other constitutional symptoms.
What about any genetic genomic study done in this case?
No, sir, we didn't have an opportunity. I know that RNA should has published, maybe others have published that you are talking about the idiopathic restrictive cardiomyopathy, but I didn't really explore and I don't think the option is there. I didn't explore it.
Because we have families of idiopathic restrictive cardiomyopathy, even now on follow-up, where the grandmother had, mother had, and the daughter has, and so it is interesting. And some of these people have a mild left ventricle hypertrophy. I am sure that there must be some, genetic mutation which can explain this thing. And we need to look at this familial or maybe genetic restrictive cardiomyopathy a little more carefully. I'm not too sure in this particular patient whether any kind of strain imaging would have helped us this or that way. But you do have MRI which shows LG positivity in LV, RA, and LA, which actually tells us that this and that is patchy. So this tells us that we are really dealing with a case of idiopathic restrictive cardiomyopathy. There could be a genetic origin.
So initially strain rate imaging showed about -19, sir. Then later on towards the end, last month it is about -17. So there is something.
Yeah, the last actually Heart Failure Association of India meeting, our group actually had presented a series of patients who presented with restrictive cardiomyopathy but had only involvement of the left atrium. The left ventricle had normal, left ventricle size was normal, the E2 prime was normal, E prime was normal, and LV strain was normal. Only LA strain was markedly reduced. We strongly believe that one of the subtypes of restrictive cardiomyopathy is a disease predominantly confined to left atrium.
Dinesh, any comments?
So I think the nephrologist approach has already been highlighted, and I think we often have to resort to extracorporeal therapies. So the data suggests that yes, they may not be making a huge difference mortality-wise, but as a short-term measure to relieve the patients of their symptoms, so many times if the diuretics fail, we are in a fix. I mean, what more can we offer these patients? And I think at times like this, probably I personally believe that we have not really explored the potential role which peritoneal dialysis can play in these roles. The gentler form of, I would say, methodology to take care of the fluid overload, and without causing too much of pressure either on the heart and being rather gentle onto the kidneys as well. So it's unfortunate that even though we realize the importance of peritoneal dialysis in such a scenario, we have not been energetic enough to really capitalize on this. But having said that, I would certainly want to learn from my cardiology colleagues today that if you look back and reflect on the improved scenario as far as the heart failure prognosis is concerned, what would be your take on, because you see, we've all these years been using all the other drugs. The only new weapons in our armamentarium have been either ARNI or SGLT2 inhibitors. I mean, that's short of the devices which you use. So can I ask, this is an open question to anyone, what is the single most thing which you believe has revolutionized the management of heart failure, with or without kidney disease?
Yeah,
is it
so I'll take it up first. Your point about peritoneal dialysis is well taken. Actually, in fact, we had Dr. Narasimhan, where we used to work with us, and we were enthusiastic, and we had quite a few patients who we managed on CAPD, ultrafiltration basically. But the outcomes are not greatly satisfactory. There is some quality of life improvement, definitely, but for a period of time they succumb. And for many people, it's a nuisance to maintain the peritoneal dialysis. The moment you say dialysis, patient will shiver. But of course, there are patients, and if there is a diuretic failure, you have to use it. Personally, I think the dramatic results are seen with ARNI. SGLT2 inhibitors still we have to have time and see. And if you seniors like Dr. J.C. Mohan and Chopra can say that over a period of time, right from consensus trial, ACE inhibitors, then beta blockers came, at every step we were thinking that we are far ahead. So latest after paradigm study and ARNI, definitely there are many patients whom we can manage better, and probably SGLT2 inhibitors even it's going to be even better.
Please don't get me wrong. When I advocated the use of PD, it is not to improve upon the mortality, because you see, ultimately mortality will depend on the heart condition. I was only wanting to relieve the patient of the symptoms. Whatever lease of life they get is probably a much better quality of life for those 6 months, 1 year, maximum 2 years. I mean, we've had some rewarding results. I'm not saying that we could prolong their lives, but whatever lease of life they had, it was reasonably comfortable.
No, I was trying to answer the first part. What is the single most important thing which has happened in the field of HFrEF? Beta blockers.
Yes.
They cut down mortality as much as 43%. If you put all randomized controlled trials together, that is the single most important thing. When we keep adding everything to that, actually, you do get in relative terms greater benefit, but in absolute terms, what beta blockers do are phenomenal. And that is why the most guidelines say that make sure that you are giving heart failure with reduced ejection fraction. My own feeling is that certain subcategories, like we talked about CKD patient, they draw far more benefit from beta blockers, but they are grossly underused.
Quite true, sir, and I'm glad you brought it up, because and you see, interestingly, most of the data as far as the CKD patients are concerned relates to atenolol. So even though we may be criticizing the molecule on other forums, but I think the majority of the data in CKD has been related to atenolol. So I think even then it's been found to be quite useful, because we all know there is a lot of sympathetic overactivity in our patients of CKD. So certainly beta blockers would be our choice. And as Dr. Ronco had shown in one of his slides, even though it's moderate evidence, and it's very familiar slide to all of us, the evidence is only with beta blockers till the time we have it with SGLT2 inhibitors and others.
There are two questions from the chat box. One is how to decide fluid intake for different ejection fraction and GFR combination. I think it's a question to the cardiologist and the brought this together. I think we are both agreed that the fluid intake has to be restricted, whether it is reduced ejection fraction or decreased GFR. The volume has to be maintained.
So, Dr. Venugopal, that's the reason why I was wanting to ask that question to everyone, including Dr. Ronco, because you see, ultimately we know we have the weapons on our side, but how to best use them? Ultimately, we have to have a particular value. You see, your patient is going to be discharged. You have to give him a particular value of the weight. That, okay, you are going back at a weight of 65. I want you to be approaching 63, but not any lesser than 63. At the same time, don't cross 66. So I think ultimately, to ascertain that weight, and that's the point I'm repeatedly wanting to make today, and I think it's very relevant in today's discussion, that ultimately it boils down to give that particular value of the weight to your patient who is not a doctor. And until the time he or she sees you again, maybe after 2 weeks or 1 month or whatever, they must try to achieve that weight. Till the time you decide the next time that the dry weight has gone up, maybe the appetite was better and patient has gained some dry weight, and that you have to revise the weight. So I think I will probably want to manage based on what we have discussed today, the clinical judgment as well as the objective tools, and that's how you use your diuretics.
Yeah. One point I want to make is that if you follow up a patient after a week after discharge, the outcomes have been found to be much better than reviewing them at a later time.
Yes.
So always make sure that your patient is reviewed at least within 7 days of discharge. That makes a lot of difference. That improves the mortality actually. So very, very important in both the nephro point of view and the cardiology point of view.
So Dr. Harikishan, is interesting. The AHA recently actually, I think a few months back, came out with a scientific statement saying that the first visit has to be within 7 days.
Yes.
Yeah.
Very interesting. Actually, this is actually usually not talked about, but they say it should be within 7 days.
Very, very important.
If the patient cannot come, at least ask your nurse to call and find out how the patient is doing, including height, weight, and including weight and complaints.
Yeah, correct.
By and large, most of us have been following this, calling patients after 1 week. Although earlier the Western literature said otherwise, but I'm glad ACC has also agreed to our viewpoint.
Yes.
Equally important to know the
question, that is, what is the opinion regarding feasibility of subcutaneous Lasix in refractory heart failure? I have not used. Anybody has any experience of subcutaneous Lasix in heart failure?
May not be a good idea because the absorption may not be good.
May not be good. Yeah.
Tissue perfusion being bad.
No, but one of the things I think we need to discuss now that Dr. Khuller is here, and the Japanese have been very fond of it. I myself have been reviewer to many articles published in European Heart Journal and Japanese Circulation Journal about use of acetazolamide and use of tolvaptan in refractory heart failure or people with natriuretic resistance. And I think it is a high time we have some kind of discussion on that aspect, because people who have written these small studies, 140 cases, 150 cases, swear by the fact that in some patients, especially those with hypochloremic situation, acetazolamide works very well.
Dr. Mohan, I agree with you. I've talked to some of the Japanese cardiologists, and they are pretty liberal in using tolvaptan in patients of fluid overload. much more than what we people do.
So I think you will have to consider that on a case-by-case basis. I mean, you see, if the patient already has a significant cardiorenal syndrome, and that's why I wanted Dr. Ronco's opinion as to would he want to grade, because barely saying that's a type 2 cardiorenal syndrome may not mean much. Because you see, if you classify further how bad is the severity of individual component, cardiac as well as renal, is important. Now, my concern with the use of acetazolamide would be in the context of significant chronic kidney disease or renal failure. I mean, you are going to have a significant acidosis, and that probably will offset the advantages which you get out of acetazolamide use.
Acetazolamide is not to be used alone. Loop diuretics cause metabolic alkalosis, and acetazolamide causes metabolic acidosis. So the combination has to be used as a sequential nephron blockade, and they will neutralize the pH effects of each other.
So I think this is like having the various components of the kidney in front of you when you're prescribing your therapy, and you're starting with the acetazolamide. You are looking at the loop of Henle. You are also looking at distal convoluted tubules with the thiazides. If they do not work like the usual ones, then probably metolazone. And then finally, what Dr. Chopra has said, I mean, you are looking at tolvaptan at the final exit point, but interesting is to add the role of SGLT2 inhibitors, because ultimately it's all about sodium. So it's just not of any use if you target all others and forget about sodium. And I think SGLT2 inhibitors from that point of view will be a game changer, certainly.
Actually, I use quite a bit of tolvaptan in people who have diuretic resistance, people who actually are not responding to diuretics, and I get reasonably good response. But this is one area where more work needs to be done.
So it's basically a combination, sir. A judicious use, because you have at least 7-8 different molecules to attack at different levels, and it's just the right combination. And now that we have finerenone, probably that inherent fear of causing hyperkalemia will not be as much as it was earlier. So maybe I think the next 5 or 10 years will be certainly a lot different in terms of the management of heart failure than what we were doing all these years.
I think we have exceeded a lot of time. Last comments by Hari.
Yeah, I think it was a very nice session, and we had 940 people attending the session. That is a very good attendance. I think both nephro crowd and our cardiology crowd were there. So it is a nice thing. I think it was Professor Ronco's presence made a lot of difference, because he is the authority in
Cardiorenal Syndrome.
Yeah, so I think we could hear from the horse's mouth. So that is the thing. So thank you, everyone. Thank you, Dr. Kullar, for joining us. And we will be collaborating with you and the nephrology team for further. There are many programs which we want to do together, because now this is the platform to take it forward.
Thanks so much. I was indeed honored to have your invitation. Thanks so much.
Thank you. Thank you.
All right. Bye.
Right.
Okay. Bye. Bye.
So thank you all from here. I'm ending the meeting now.
Thank you.
So there was a time when I was doing MBBS. If we mentioned beta blockers in heart failure, you were sure to fail.
Yeah, you're offline?
Monique, are we offline?